Welcome to the MindSea podcast series, Moving Digital Health. Our guest today is Kiser, CEO of Arrive Health, a health tech company that works with hospitals and health systems to surface pricing information on prescription drug transactions in real time so medical providers can find the best options for their patients. Thank you for joining us today, Kyle.
Glad to be here.
So, could you tell us a little bit about your background and how you came to lead Arrive Health?
Sure. Yeah. My background's primarily have been in healthcare in the U.S. Sort of come from an employee benefits perspective. Come out of that world. My family's business was in the employee benefits business. So I literally grew up on that side of it. I was a wholesaler for employee benefits products. Kind of got the bug for startups at Principal Group, which had a health plan and a wellness business. Was a part of that wellness business that was kind of like an entrepreneurship experience inside of this big, many thousands of people financial services company. And that led me to, digital health path. So early employee at Welltalk, early employee at a company called Catapult Health, then joined the original team here at what was RX Review at the time, and recently has been rebranded as Arrive Health.
Okay, and how long has Arrive Health been an entity?
I'm in year 9, so we've been at it quite a while.
Oh, yeah, nice. So maybe you could tell us a little bit about some of the barriers to care that Arrive is helping to solve for patients in the US.
Sure. Yeah. Fundamentally, the problem we're trying to solve is that we're trying to introduce consumer choice into the clinical decision-making process and the patient experience. That feels like something that should have already happened, right? When you say that out loud, you
Mm-hmm.
go, well, of course there's consumer choice. We're the kings of capitalism in the U.S. Surely there's consumer choice, but there isn't. And what's happened over the last couple of decades is that we've shifted cost onto the backs of patients in the forms of high deductibles, and really hadn't shown up with the tools to help those same patients make more informed, transparent, and consistent decisions around formulary, pharmacy selection, cost generally, affordability, and ways to support their ability to pay. And so we've built a network that connects to the point of care when those decisions are originating with the provider, that drives real-time, patient-specific, moment-in-time specific pricing into the decision-making workflows of doctors, and with alternatives of lower-cost options to support the patient. And then now are connecting that into the patient experience in a variety of ways. But that's the network we've been building, is taking those tools and putting them into the decision-making workflows that to sort of matching that specificity of choice with the decisions as they're happening, be that in the hands of providers, care teams, or patients.
Mm-hmm. So currently, do clinicians have any visibility into cost, like at that moment when they're making a prescription?
They do now. They didn't, and largely, the advent of e-prescribing, which is now 20 years in, um, actually restricted consumer choice in a lot of ways. Like when you had a paper prescription, you could actually take that paper prescription to multiple pharmacies and understand price. When we
Right.
started to electronically route prescriptions, it went directly from the EMR system to whatever pharmacy you decided while you're sitting in that clinician's room. And that fundamentally limited consumer choice, because the price at your retail pharmacy or your mail order pharmacy, or the one that's in network for your health plan, may be different. And so the ability to understand those differences at the point of order has really been absent for the life of e-prescribing. And so that's
Mm-hmm.
what we're bringing into those decision-making workflows, is the ability to see real-time, patient-specific, moment-in-time specific pricing, so that that level of consumer choice can be reintroduced at the outset of that process.
Okay. And how does the cost of prescription drugs impact adherence?
Possibly. It's the primary cause of non-adherence is the inability to afford it. We did a survey recently and found that 64% of patients were going to avoid taking the medication, or take it differently than prescribed because of cost. So it's a massive impact on patients' ability fill their meds, take their meds, be compliant with that regimen, and treat their condition.
Hmm. And so, what is some of that patient behavior like? Do they think, "Oh, I'll, spread out this medication. I won't take as much," or you know, what's the psychology behind their thinking of how to deal with that situation?
It's sort of generally skip or delay are kind of the two things that were characterized in our research.
Right.
Um, anecdotally, I think it's think of this scenario where medication's prescribed, you go to the pharmacy and you don't know that you don't know the cost of that until you arrive at the pharmacy counter to pay for it. And so at that point, you either find out a prior authorization was required and you can't fill it, or you find out that the price is something that you can't pay. And either of those things cause walkaway. Just they don't come back, right? So those are risks to delivering better care because we just patients met with that friction often just don't come back.
Right. You just get that sticker shock and be like, "Oh, I had no idea it was going to cost that much, so I guess I can't take this treatment."
That's right.
So, what are some of the common reasons providers don't talk with patients about how to save money on their prescriptions?
Largely, it's been just because they didn't have the information available to them. So before a network like ours was serving providers, they just didn't have visibility to that information. So the information that was available inside of the EMR system were largely flat files that gave an indication of kind of a group and a plan level insight into benefit design, but not any specificity around price or alternatives or medications that would be suitable alternatives based on price, or pharmacies that would be suitable alternatives based on price. It just wasn't there. I don't think it's been an unwillingness for providers
Hmm.
to want to engage in that type of conversation. I think that providers have been largely trained that information is not available. And so now it's our burden to bear to say, no, it's here now, and present that in ways that's beneficial to their decision making process and their workflow.
Hmm. Uh, and what are some of the other factors aside from price that might influence clinicians' prescription of, which prescription to, fill for, that specific patient?
Largely training. So there has been some research that could tie back sort of the training program that a provider participated in based on prescribing patterns. So that's one. Believe it or not, there's no spell check in an EMR, so it's a lot of times it's what they can remember and what they can spell
Right.
is a huge influence on because you have to be able to actually type in the first several letters to get an auto-populate screen to select a medication. So
Yeah.
those are both huge factors that influence decision making.
Hmm. And so, what about the data side of drug pricing? Where does that all that information come from in the EMR to help make that decision?
We're connecting directly to health plans and pharmacy benefit managers who are the source of that information. They're the ones adjudicating that claim, which is how we're getting a real-time, patient-specific, moment-in-time specific insight into that price.
Hmm. So, from a software development background, so at MindSea, we deal with a lot of integrations, with different health data and providers. I know that sounds like it must have taken a long time to get that right. Uh, do you have any insight into what that process is like to connect the dots there?
It's more a business problem than a technical problem. The tech, not to de-emphasize the
Yeah,
technical
fair
work.
enough.
The
Yeah,
integration work is tough, but really the hard thing with building a multi-sided network is that on one side of your network, the supply side inventory of that network doesn't want to commit to integrating until you have providers that are using the tool that are delivering value to them. The providers on the other side of the network don't want to use a network that doesn't have relevant data in it. So you're sort of stuck with this chicken or the egg problem when you're
yeah,
building these things
yeah.
from a cold start.
Very, very
So
familiar with this problem.
yeah, so that's the hardest thing to overcome is that first initial, gaining significant scale on both ends of the network so that you have something that's relevant. Um, Once that's achieved, um, there's still a lot of, complexity in those integrations and not a lot of consistency today from one to the next. But that's changing, and the standards body for e-prescribing, NCPDP, is making progress and developing a standard and adopting a standard. CMS is mandating now that if you're a Part D plan, so a Medicare supplement plan that provides outpatient drug coverage, you must have the ability to integrate with real-time benefit tools, which are the types of things we do. And so there's a lot of good things happening from a regulatory perspective to bring more consistency and drive more adoption of these types
Mhm.
of tools. But there's still a long way to go.
Okay. And in that process, did you have resistance from some manufacturers to, take part in a marketplace like this at all?
We don't work directly with manufacturers at the moment. We work with the health plans and the PBMs that derive
Oh,
that
okay.
pricing.
Right, right. Got it. And how about on their side? Like, when you were first proposing this model, was it generally everyone was on board, or was it, difficult to get everyone to participate?
No, I think it was one of those ideas whose time had come, right? Is that there's
Mhm.
a lot of benefit to the health plans and the PBMs to integrating in these types of tools. So, for example, the opportunity to avoid prior auth altogether has a lot of patient benefit. That it drives usually to a lower cost medication that benefits the patient and the health plan, and avoids the administrative costs associated with administering a prior auth, which is of a huge benefit to the health plan or the PBM, depending on who's doing that work. So there's a lot of value to that side of the network. And then on the other side of the network, providers, we were hearing in the early days the number one requested thing from an ambulatory provider was the cost of medications, just because all those things we already talked about, of the barriers that exist for patients if you make these choices. And a lot of times the choices are not necessarily things that are clinically significant. So, albuterol is always an easy example, because albuterol comes in a bunch of different forms, Haler and all kinds of forms. And there's, all the news now about the shortages, but
Mhm.
um, there's health plan preference on which form, because they've negotiated specifically for a form, a lowest price. But the provider
Right,
didn't have any
right.
visibility to that at all, right? So, and that answer might be different for each health plan. And so if you see 30 patients in a day and there's 5 or 6 health plans relevant in your market, that there's this really complex decision criteria to get to the right answer for the right class of drugs for the exact med that payer may have negotiated best for. Well, this resolves that, right? On that side, we say specifically, you're trying to take medication A, you're trying to prescribe medication A. We bring back alternatives of medication B or pharmacy B that are lower cost options for that patient based on our interaction directly with, which is a huge benefit to the provider, patient, and creates a system where they're going to reduce callbacks. They're going to have less friction within those clinics.
Mhm. So the lowest cost option might actually be different from one patient to the next with the same condition, depending on their plan and the other factors, right?
Exactly. Exactly.
Okay. And what about the impact of recent state and federal drug pricing transparency laws in the U.S.? Uh, how has that impacted the landscape?
The CMS rule has been beneficial. We've seen folks come to the table as a result of that. I think the opportunity right now is that it's currently only focused on uh, Medicare beneficiaries, Part D membership. I think there's a great opportunity to expand that, to regulating ERISA, to other federal beneficiaries like DoD and VA, and exchange business. So I think expanding the surface area that the government can influence around the adoption of these types of tools is a great opportunity. Um, but it has brought people to the table. We've been less involved with some of the other price transparency rules around non-pharmacy related things like hospital price transparency and health plan price transparency for procedures. Not better
Right.
world per
Yep.
se, but on the drug side, we've actually seen uh, good adoption. We've seen folks come to the table. We've got over 200 million health plan lives addressable within the network now, and some of that is a result of some of these regulations.
And how big does the Arrive Health network span now? Is that across the U.S.?
Yeah, yeah. So we've got over 300,000 providers connected on the demand side of the network. We've got over 200 million health plan lives in the network on the supply side of the network. We're on track to do 150 million or so transactions this year. So it's reached some significant scale and continuing to grow. We're looking at pretty sizable growth in utilization of the network year over year. Our goal is over 100% growth from a revenue perspective, a recurring revenue perspective from January to December. So we get a lot of good things out of us.
Wow. Yeah, excellent. It seems like you certainly found that product market fit there. Uh, what does the world look like when more providers start using these tools?
Well, I think it probably looks a lot less frustrating for patients, right? Like that scenario where you show up at the pharmacy blind, hopefully starts to go away. I think over time, as these are more adopted at the point of care, as they're better understood at the point of care, then these are conversations that patients can have with their provider, which is ultimately what they want in the first place. Patients seek these answers from their providers, but largely the providers haven't had the answers, not because of an unwillingness or lack of effort, because the data wasn't there. So, I think the what the world looks like is that the trust between patient and providers, which is inherent, is enhanced and empowered with information that allows that conversation to happen the first time, and not as a consequence of a claim being denied or as a consequence of learning that you can't afford the medication. But that's a conversation that a patient and a provider can have in the clinic as that decision's being made.
Yeah, and as a patient, you're going to feel really good about knowing that you're getting the best option there.
That's right. Exactly.
And so, what's next for Arrive Health? Like, aside from this very specific problem that has, you've really been able to come up with a solution for. Is there other ways that Arrive Health is thinking about how they could help patients?
Yeah, I mean, to us, it's definitely not stopping at the point of care. Our goal is to create this digitally enabled marketplace that meets decisions with specific insights around how to drive a lower cost, more affordable, more accessible choice. And so what that looks like for us is connecting care teams and patients into the process. So today we've built sizable scale at the point of care. We've got a network that's delivering value at the point of care. At the beginning of the year, we bought a company from UPMC that's focused on medication adherence, that's doing AI-driven outreach directly to patients and connected with the care team interaction, so that those downstream of that initial decision can do automated outreach and check in around side effects and refills and just how things are going from a patient perspective.
Mhm.
Because pharmacy really starts to be an opportunity for continuous care. Because the pharmaceutical event is the most frequent thing that happens in a patient's experience more often than not.
Right.
So what we want to start to drive is that continuous action off of that pharmaceutical event. And what that'll allow us to do is to start to tailor really hyper personalized messages to patients around whatever it is that we learn as a result of that encounter with the provider. So if they're on a diabetes med, then there's some really specific things that need to happen if you're a Medicare member on a diabetes med. So we want to start to integrate messages from their health plan that help them understand gaps in care that may exist, affordability solutions that may be out there, ways to overcome prior authorization or other friction in the process. And we don't want to do that in a connected and automated way from point of care to care team directly to patient, and start to create that consistent experience that honestly feels a little bit more like every other e-commerce experience we have in our life, but
Right.
sadly
Right.
doesn't happen very often in healthcare.
Yeah. And in terms of the range, like if we take a specific example of a common medication that's prescribed, what can be the difference from like the highest cost to a lower cost version?
Highly variable based on condition, but it can be the difference between a $0 option and a hundreds of dollar option. No, no kidding. I mean, we did the research and found that nearly half of the time there were $0 options available when a patient was prescribed something that was $50 or more.
Yeah.
And so it's really the difference between paying nothing and paying something. And there's a lot of cases where that's clinically justified and important. What we're contending is there's also a lot of cases where it's just the visibility of the information is what's preventing that choice from happening.
Hmm. And is there value to giving the patients the visibility as well, and kind of exposing that information so they can see it themselves, or is that kind of dangerous and has some potential negative impacts?
Hugely valuable. I think especially as we've shifted benefit design, that the first several $1,000s of care is the patient's responsibility, that
Hmm.
it is critical that we now provide the ability for them to understand cost, understand options, and understand, in many cases, things outside of their own benefits, because ultimately we need them to make more informed consumer centric decisions, because they have to, right? Like the price, the cash price, or the price through a discount card, or the price of your benefits are all things that patients are considering today. It's already happening. So we need to ensure that we're doing that in a connected way with the provider that's guiding them around that decision. As we mentioned before, that's the trust, right? Like that's who patients are seeking those answers from.
Yeah. Well, thank you for joining me, Kyle. Really appreciate the your perspectives on this issue and learning more about what Arrive Health does.
Thanks for the invitation. Enjoyed the conversation. Thanks.
Excellent. Well, and thanks for everyone who's listening and joined us on Moving Digital Health. If you enjoyed the conversation, please go to movingdigitalhealth.com to subscribe to the MindSea newsletter and be notified about future episodes.